So as much of a what kind of specialities do we have here? Very broad mixture. So different groups of people find different bits more relevant than others, and unfortunately, as an anaesthetist, a lot of my examples or kind of anecdotes are going to be based on hospital medicine. I'll try and cover some psychiatry. It seems to be a lot of psychiatrists. GPs are slightly different setup and we'll talk about that as well in a second. Okay, slider seems to work, and that's the first thing. So the purpose of today is to help you navigate the health system. We all, as we're going through our training, as we work in the NHS, have frustrations. We see areas that we think could be improved. We see inefficiencies, but we don't always know how to approach making them better. And particularly when you get towards your end of your training and into whatever roles you take on in the future, and into kind of less rotational jobs, let's put it that way, you might want to actually develop your services and expand them. And one of the big problems that's happened in the NHS is that things happen in isolation. For example, there's a lot of cases where services have expanded without looking at the knock-on effects to other services. So in my world, we've got things like a lot of surgical specialties have expanded. They've taken on bigger, more complex types of operations, but they haven't looked at the post-operative impact or the theatre impact, or they haven't factored that into their plans. And in other specialties, you might find that the impact of changing how a clinic runs might have knock-on effects for general primary care, or into the community. So it's looking at how to look at it in the whole. So we're trying to help you, give you some information, and this is not going to be the be all and end all, but it's a kind of base layer of how to navigate the health system. It's also important that we're not trying to say that you have to, count every penny. Your focus should also always be the clinical outcomes or clinical. And so we want you to be clinical driven, but just aware of the financial implications of what we're doing. Whether it's looking at changing our equipment, whether it's looking at expanding our services, what are the financial implications of what we do? So it's not about penny pinching or always not impact efficiencies and things like that. It's a slightly different focus. So the kind of things we're going to cover today, and we're going to try and pace it out a little bit so that we have regular breaks throughout the morning, because it's going to be just me and you're going to be fed up of me talking quite quickly otherwise. We're going to cover a little bit about the NHS structure, a bit about how services are paid for. I'm going to talk about costing and PLICs, because that's a relatively new way of of looking at finances and how you look at your services. And then finally, we'll cover business cases. As I said, we're going to start very basic. Different people will have different levels of knowledge already. And so I apologize if I'm, going through some very basic stuff, but I know that there's a breadth of people here. We're going to be talking very broadly. So there'll be specific things that might be different, or things that are very specific to your individual organisation or your particular specialty or your area. But again, this is a kind of we're going to talk quite broadly and some quite generic stuff before going down to some the nitty-gritty later on. Okay. If you have any questions, please let me know. I'll try and stop every so often after each topic, and we'll go through any questions. Hopefully you've been sent out a copy of the handout. Obviously it hasn't got the kind of Slido bits in it, but it's got an overview of the slides, and it's got some few slides that are kind of so detailed that I've not actually included them in the slideshow bit. But they are there for your reference to try and give you a heads up of what we're going to be talking about. Okay. So the first thing we're going to talk about is value in healthcare. Now, it's a term that's bandied around quite a lot. It is what we aim for in healthcare in a finite system. So we haven't got endless amounts of money. We have to then look at how the best way we can use the money that we have. Okay, and that's called value in healthcare. I'm going to go into it in a little bit more detail now. So there are three types of value in healthcare. Okay, there's something called allocative value, and that's basically often at national level or at the kind of commissioner level. It's how you allocate the resources that you have. So you have X amount of money or X amount of staff, and it's how you allocate that around. And that's called allocative value. The other name for it is economic value. The one we're going to talk about a bit more, because it's probably the most relevant to us as clinicians, is something called technical value. And that's making the best use of the money that we have, or the resources that you have, because it could be money, could be staffing, could be something else. So it's making the best value use of that stuff. It's also called efficient value. The one that is less finance orientated, but is equally as important, is something called personalized value. And that's understanding that when you're looking at outcomes, or when you're looking at decisions, everybody has things, everybody values different things. And so an example, kind of an official example, is when the Virginia Mason Institute is very big. It's an American kind of healthcare system. Is very big on value-based healthcare, and they did some work with a health board in Wales. And one of the bits of work they did was to look at a neurology clinic, and they asked the clinicians to rate on a 1 to 5 scale of what they felt the most important things, or what their focus was from the consultation, and they did the same thing to the patients in the waiting room. And what you found was that the clinicians were rightly focused on things like diagnosis, preventive disease progression, and treatment, whereas the patients were focused on having more energy, being able to go to work, better sleep, less tired. And overall, those things overlap for the most part, but they are different. And so it's understanding that different people have different values. In my own personal kind of experience, I've had patients who coming for an operation. I see them in the high risk clinic, and there are some patients that are very high risk for surgery, but the thought of them having cancer just means they want to get rid of it. They can't live with the thought of having cancer. And there are other patients that are probably less high risk, but the impact on their life, and you talk to them about the fact that they might not be able to walk their dogs, either in a kind of medium term and long term, and and they kind of go, actually, I'd rather live my life to the full and walk my dogs for as long as I can, rather than have surgery now and then not be able to do that. So it's just identifying that different people have different values. Okay, that's also called effective value. Now, we're going to make this into an equation, the technical value bit. So if you had value equals, and then a fraction, essentially, something over something, okay, what would X and Y be? So value equals one word for the top line, one word for the bottom line. So what word would be the top line? What would be the bottom line? If you had to define value in a particular way. Okay. So we seem to have got cost as a bottom line. That's right. Okay. So Y is the cost. I've yet to see the correct word for the top. Oh, somebody's got the right word. Okay. A couple of people got the right word. Okay. So if you look at a lot of definitions from people who are not clinicians, or who are or historically from economists, you will write in saying outcomes over cost. Okay. However, we are not economists. We are clinicians. And so the best word to define value in this context is quality. Okay. And so we want quality over cost. And I'll come to a reason why that is. Now, there are three domains of quality. And it includes some of the stuff that people were talking about. So there are three. So this is a interview question that you occasionally comes up, is what are the three domains of quality, and how are you going to improve them? Okay. And if you look at the NHS Constitution and various other NHS documents, you'll see this come up a number of times. The first one's clinical outcome. Okay. Now, it is very important to note that there is no specified clinical outcome when we're looking at value. Okay. So you can use mortality, morbidity, readmission rates, complication rates, quality adjusted life years. You can use whichever is the most suitable for whatever you're measuring. And there doesn't necessarily have to be a specific timeline for outcomes. And again, unfortunately, it's a surgical example, but if so one of the things they've done at I'm sure it was a national study, but they've used it at my hospital, was that when they do a laparotomy, they do a specific type of closure. It takes probably half an hour longer to close a big laparotomy wound, but it doesn't affect patient complications immediately. So it doesn't affect your kind of post-op stay. It doesn't affect your 28-day readmission rate or mortality, or doesn't get them home length of stay. Doesn't affect any of those aspects. What it does do is in the over 10 years, it reduces the risk of incisional hernia by about 70%. So that's a time frame that we don't normally consider in medicine in terms of when you're looking at business cases and things like that. So it's important to look at or measure the right thing that's suitable for whatever is that you're trying to measure, look at. Okay. So clinical outcome. The other two things are patient experience and patient safety. So if you're coming up with a quality improvement project, a service improvement project, or whatever it is you're kind of looking at, and what you try and do as we're going through the morning is, if you have a gripe, a thing that you want to improve, or something you can think you can do better, try and frame it as we go across the day in this context, and we can talk about it at the end if there's time. Okay, we can try and get people to give up examples, and we can try and talk about it in a bit more detail, how you would actually go about it. Okay, so look at these three areas. Ideally, you want an improvement in at least one. Well, you need at least one. Ideally, you want it in 2 or 3 of these domains. For example, you can run a one-stop clinic, okay, or you can, which then, it improves clinical outcomes because you can improve, they get seen all, they get all their investigations, everything done in one go. Patient experience is better because everything gets done in one go, and patient safety means that you have less complications. So that's also better. An example from my world that we have used is we have a very high emergency list of needing emergency operations. We haven't got the right capacity, so we expanded one of our second emergency theatre into the evening. And we say that improves clinical outcomes because we're doing patients earlier. So we're operating on patients earlier in their stay, so they get better. They're less complicated. They become, they're less septic. An appendix, for example, gets operated before it bursts or before it perforates or whatever it is. Patient experience, they're not starved every day, only to be bumped the next day. And patient safety, because we actually do a combination of things. We actually do, because of that extra time in theatre, we do less operating overnight, which means that improves patient safety. So what you want to do is make sure your improvement in quality covers multiple domains. And then costs. Costs are generally divided into 2 areas. Okay, there's your revenue costs, which are your day-to-day spending costs, your day-to-day running costs, and your capital costs are your big budget expenditures. The important thing in terms of budgets is that capital costs are generally one-offs. Okay, so they're one-off purchases. Okay, whereas revenue costs tend to be recurring. So if you employ somebody, that'll be a recurring cost because you're employing them for multiple years. The capital cost is a one-off purchase. You might spread it over multiple years, but it's a non-recurrent thing. And that's how most budgets are divided up into. Now, Michael Porter, who was as a Harvard business professor, came up with this concept, broadly speaking, of value. Now, there are two ways of looking at it. When you are putting forward your idea or your proposal, you've got to show that the quality outweighs the costs. So what I can knock down every hospital in England and build a new one, and generally the quality will probably improve. But in some hospitals, that improvement won't be worth the millions of pounds you spent on it. In some hospitals, like in Leicester, it would be very much worth the money spent on it. But that's why you've got to justify it. The other thing is that overall, if you improve quality, you will reduce costs. The problem is it may not be the cost to your department. It may not be the costs to your organization. Okay, it may not even be a financial cost that you're reducing, because there are other costs that we have to factor in, things like environmental costs and societal costs. Now, if you asked me this 10 years ago, environmental and societal costs weren't factored in. So if you tried to put a proposal and said, oh, it will benefit us from an environmental view, or it'll have societal benefits, it wouldn't hold traction. But increasingly, we are factoring that in. And we are factoring it over multiple years. Those benefits. Okay. So, right, I'm going to go into the structure of the NHS. So obviously the NHS has been around for a long time. It's gone through multiple different changes, adaptations, and various other things. And it's happened multiple times. So even in 1948, it wasn't, you know, what they did at that time, they didn't build anything new. They just took what was existing and put it under, nationalised it, essentially. Okay. And then in 1962, the health secretary at the time decided that they should try and build a DGH for every 125,000 of the population. And then what happened? They ran out of money. So ever since the NHS has come about, finance and funding has always been an issue. This is nothing new. In 1974, you got the development of health authorities. In 1992, you got this concept of the internal market where organisations were competing against each other for to try and for work, essentially. Okay, and the theory at the time was that that competition would improve quality, and that's fine when money is not really an issue. It's not the defining characteristic when you're looking at a commissioning. What's happened subsequently, and what we've realised over the last probably 30, 40 years, at least 30 years, is that when money starts becoming an issue, then it's a race to the bottom, and you end up losing quality because of trying to save money. So you had the 2000 NHS plan, and then so the last major, probably significant reforms were the Health and Care Act of 2012, the Lansley reforms. Now, they were conceived by Andrew Lansley, who became health secretary when the government when the Conservatives were in opposition. And the problem was that by the time they came into power in 2010, there'd been the financial crisis. And so the landscape that the reforms were implemented on had changed significantly. The other thing, as with everything in the NHS, is whilst the ideas might have been sound, the implementation and the kind of nitty-gritty was never really factored in, and it's probably wasn't successful, put it that way. And so they quite quickly realised that that competition, which the Lansley reforms built in legally into the framework, was not good. And so for 10 years after that, there was the NHS tried to manoeuvre itself to try and reduce competition, but while staying within the legal framework. And so the Health and Care Act in 2022, which I'll go into in a bit more detail in a bit, basically was just tidying up. It was just tidying up the issues that the Lansley reforms had created in 2012 and made what they were already doing legal. So they weren't major changes, but they were more about collaboration and organisations working together rather than competing with each other. So I'm going to talk about money now. Okay, so and a lot of this is there's a video that you may have seen, but I'm going to play it anyway for those of you who haven't or didn't get a chance to see it. But the amount of money that the NHS gets is determined by Parliament, and specifically the Chancellor and the Treasury. It's set every 3 years or so by the spending review, and then adjusted by the budget report, which is annually at the moment. So what I want you to do is rank in order are the budgets of the Departments of Health, Education, and the Ministry of Defence. What do you think? Who do you think gets the most? Who do you think gets the least? So when we used to do this in person, it was a game of higher and lower, and used to kind of put a number in, and people would then decide whether the Department of Health budget was higher or lower, education budget was higher or lower, and defence budget. But Slido, we'll see what we can do. Another 10 seconds or so, and then we'll look at the results. Okay. So health, defence, education. So we all, as clinicians, know that health is probably the biggest. But what we always forget is that defence and education. Okay, so health is not far off. This is in billions of pounds. Okay, this is where my graph skills have been shot in my final exam. So the numbers on the axis on the side is in billions of pounds. Okay, so education is probably in the 80 to 19 billion pounds, and defence, the poor Joint Chiefs of Staff are kind of only around the just over 50 billion pounds a year. Now, a lot of people say, "Oh, what about the Trident? It's £1 billion in itself. All the aircraft carriers, things like that. That cost is spread out over 15 to 20 years. Okay, so per year, annually, this is the budget we're talking about. Okay. So we're close to, we're close to half of all government spending is on health. Now, this is I found this today. That is on the BBC News. So health spending is now nearly, or not, just shy of half the public service spending. The other things in the Institute of Fiscal Studies suggested that despite that, we're still underfunded compared to inflation. But it is a question of where the money's going to come from. That's we're not going to get political, but it's going to be tough for whoever gets into power after the general election to make sure that we get the increases that the health system needs without compromising the rest of public service spending. Okay, so we look at the absolute numbers. So this is how spending has changed over the last few years. So there was a big increase between 21-22 and 22-23, and that's partly because in 20 to 21, which was the COVID year, money was thrown around like nobody's business. But the increases are much less significant. So from this graph, you can see that the orange bit, which is the money that NHS England gets, so the whole of the bar is the total spending on health. Okay, you can see that by far the most money goes to NHS England. Okay, and the capital funding is growing slowly, but for example, in the last year, the year just gone that finished in April, and previously in the kind of late 2010s, what was happening is that when the providers, so NHS England and the trusts, overspent in their day-to-day costs, what was happening is they took money from the capital budgets. Okay, so you couldn't build or develop or buy big services, buy big things, because that money was taken away to fill in the overspend in the day-to-day running costs. Now, the other thing you see is that the blue bit, which is the Department of Health and Social Care, so they fund lots of different bodies from with their little blue bit. Okay. And I should put a slide out for this as well. Okay. There are multiple bodies that the Department of Health and Social Care fund. Normally I say how many can we name, but okay. Some of these you will have heard of, some of these you may not have heard of. So most of what we're talking about applies to England alone. Okay, there are a handful of bodies, so that budget covers the NHS in England. Okay, the health is a devolved entity, so Scotland, Wales, and Northern Ireland have their own. They decide how much of their budgets they want to spend on their health system from their grant they get given, or either allocation they get given. Okay, there are some of these bodies that have a UK-wide remit. Again, so they've got slightly more funding from different bits and pieces. So you've got the Medicines Healthcare Products Regulatory Agency. They approve medicines and products. Things like the vaccines was what they became famous for recently. And then you've got the UK Health Security Agency, which is a relatively new body. It was formerly called Public Health England, but they changed its remit, gave it a bit more of a UK-wide remit as well. And then you've got these kind of special health authorities. So Blood and Transplant, Business Services Authority, which looks after prescription charges and pensions and other kind of back office stuff. NHS Resolution, which is the it's not a new name, it's a quite old name now, but it's basically the company that looks after the area that looks after litigation. So they run the indemnity schemes, they look after patient safety, and they kind of help with the litigation side of things. And then you've got the Counter Fraud Authority, which is a very small body. Then you've got these kind of non-departmental. These are more the arm's length bodies. So you've got NHS England. Okay. So we've seen that most of the money goes to NHS England, but all these other bodies that we're going to go cover are funded from that little blue box of money at the beginning. So you've got NICE. Now, Health Education in England and NHS Digital existed as separate entities until last year, 2023, April 2023. And they no longer exist as separate entities. So Health Education England has been absorbed into NHS England. And so it's part of NHS England's Workforce Directorate. And NHS Digital has also been absorbed into NHS England. There are two reasons for this. Three reasons. One, it's a cost-cutting measure, because by absorbing in, you can avoid duplication of work. Two, there was a lot of duplication of work and working very much in silos. So NHS Digital will do something, and then the NHS England Digital Directorate would do something separate, and they would be working on similar things, but without talking to each other. And then thirdly, when the government, whichever government historically, has said we're going to protect the NHS's budget, they only ever talk about NHS England's budget. That's what they mean. Okay. And so what was generally happening is the Department of Health and Social Care's budget was being massively slashed to ensure that NHS England got the kind of the increases or the money that it needed. But it meant that all these other budgets for all these other agencies, so whether it's Health Education England, all these other ones got massively slashed as well. So by putting it into NHS England, you kind of protect it to a degree. So you've got the regulators. so the Care Quality Commission, you'll have heard of, CQC. And then you get to the more niche ones. So you've got the Human Fertilisation and Embryology Authority, you've got the Human Tissue Authority, the Health Research Authority, and then the new one, which is has been around for a few years, but only became a statutory legal body in itself a couple of years ago, which is the Health Services Safety Investigations Body, which is similar to the airplane investigations body, accident investigations body. Okay, so from NHS England, you get your integrated care systems, and then you got your NHS providers. And I'm going to come back to that in a bit after the animation. I'm going to come back. So we're going to play the animation. Oh, you know what? I don't think I included sound. Okay. I'm going to stop sharing for a second because I don't. So hopefully you've at least seen this video briefly. I'm going to play it again for those that haven't, and then we'll take a brief pause just to answer any questions, and then I'll move on.
This animation gives an overview of the structure of the NHS in England and describes how the money flows. How public money is spent is determined by Parliament, and more specifically, the Chancellor of the Exchequer. Money allocated to healthcare is determined by the Spending Review, which is usually every 3 years, and amended annually by the Budget Report. The government department responsible for healthcare is the Department of Health and Social Care, which has the largest amount of pre-allocated public money, with an annual budget for 2023 to 24 of £188 billion. This is divided into £176 billion of revenue funding to cover day-to-day running costs, such as staff salaries and medicines, and £12 billion of capital funding to pay for infrastructure and maintenance costs. Health is a devolved function, so this funding is only for healthcare in England, as social care is funded separately via local authorities. From the budget, the Department of Health and Social Care has to pay its internal costs and fund several executive agencies, special health authorities and arm's-length bodies. The biggest of which is NHS England, which legally merged with NHS Improvement on the 1st of July 2022 as part of the Health and Care Bill. NHS England has now also merged with NHS Digital and Health Education England. NHS England received the majority of the Department of Health budget, with funding for 2023 to 24 of £160 billion. NHS England works via 7 regional teams to support the delivery of the NHS long-term plan. The plan was published in 2019 and outlines the key ambitions for the health service for the next 10 years. To create a service fit for the future and get the most value for patients out of every taxpayer pound. The Health and Care Bill builds on the long-term plan to support integration. NHS England has a budget of £27 billion for directly commissioning services, including some primary care services and public health. It directly commissions military healthcare, health services in the justice system, for healthcare for children, young people and adults across secure and detained settings, and specialised services. There are 154 directly commissioned specialised services, which are grouped into 6 programmes of care: internal medicine, cancer care, the trauma programme, women and children, blood and infection services, and mental health. Over the next few years, NHS England will delegate some of its commissioning responsibilities to local commissioners, with pharmacy, ophthalmology and dentistry services fully delegated by 2023. 9 regional committees are being created to commission specialised services from April 2023. They are joint committees between NHS England and the relevant integrated care systems in each region. Following several years of locally led development, 42 integrated care systems, ICSs, were established on a statutory basis on the 1st of July 2022 as part of the Health and Care Bill. Integrated care systems have four main purposes. They bring partner organisations together to improve outcomes in population health and healthcare, tackle inequalities in outcomes, experience and access, enhance productivity and value for money, help the NHS support broader social and economic development. The new ICS are led by an Integrated Care Board, ICB, and an Integrated Care Partnership, ICP. The exact composition of both the ICB and ICP will vary between areas, but as a minimum, the Integrated Care Board will include a chair, the CEO, and representatives from NHS providers, general practice, and local authorities. ICBs replaced clinical commissioning groups, CCGs, and are now responsible for developing a plan for meeting the population's health needs, managing the NHS budget, and arranging for the provision of health services in the integrated care system. The majority of NHS England's budget, £107.8 billion, is allocated to ICBs for commissioning local health services. ICBs plan and commission services for their patients. The Integrated Care Partnership will also include the ICB CEO, local authority representatives and NHS providers, but may also include representation from other organisations. The Health and Care Act has seen a shift to more strategic commissioning and a more collaborative approach to planning care. Allocations are made from NHS England to ICBs as a system funding envelope. ICBs will have the flexibility to manage resources within this envelope to deliver agreed local priorities. ICBs will agree on contracts with providers, with increases expected to be based on aligned payments and incentive basis. Organisations within ICSs have to adopt and adhere to a shared control total, which in effect binds them to meeting a collective target for financial performance. So, in summary, money flows from Parliament via the Department of Health to NHS England, and in the most part, integrated care boards to the organisations that provide patient care.
Okay. So I'm going to briefly come back a bit because the first bit of the of what we talked about is very based into what we talked about. There are some terms there that probably are more complicated than they need to be. System funding envelopes, basically it means that the ICB gets X amount of money and they get to decide how to spend it. That's basically what that means. And so they can spend slightly more on community care, they can spend slightly more on mental health care, or they can put it all in acute care, well, however they want to determine that, depending on the needs of their area. And it also, the system control total means that as a system, they need to meet this total, which is normally at least break even, if not like make some money. And that's because historically, pre the latest version of this system, what was happening is that often the community mental health trusts would either, because of the type of contract and payment systems they were on, which we'll talk about in a bit, would either break even or make money. And then acute system would lose money, and there was no incentive for them to work together because of the types of contracts they were on. They both lose out essentially, and so there was probably stuff done in hospitals that probably needed to be done in hospitals, and the hospitals or the acute providers didn't want to send it out, and the community and mental health providers didn't want to take it on. essentially. So the system control total means that as a system, they've got to achieve whatever it is that they've got to achieve. Now, occasionally, or sometimes it's a negative value. So they, if, for example, last year, you had one organisation who lost maybe 50-60 million pounds over budget. There's no point trying to get them to say, right now next year you're going to be break even, because that's just realistically not possible. So they might agree to be only 40 million pounds over, and as a system that will have an impact. So as a system, you might agree to be only 20 million pounds over. The individual organisation agrees to be 40 million pounds over, whatever it might be. And that's what control total is that it is being able to at least predict how much you're going to be over or underspent. There are some organisations, and there's an efficiency factor every year. Okay, so if you had a positive balance and you made money almost, then your control total next year would be to make more money, so that, again, to offset your system control total. So it's a bit like that. Okay, and I'll get questions on that in a second once I go through this next bit. So we talked about integrated care and integrated care boards, integrated care partnerships. And so they came about in the latest reforms. So they kind of went through in 2022, but they are based on basically some requests that NHS England made back in 2019, okay, just before COVID. The NHS England submitted a paper to the government that said that these are the things that we need to, legal things that we need to make to kind of change how we work. And so the government kind of accepted most of them, and essentially there's a the main things are in the context of what we're talking about is this duty to collaborate. Okay, so beforehand there was a duty to compete. So it meant that the commissions had to put every service out to tender, and then the organisation had to compete for this service. And often it was the lowest, the people who could offer the lowest financial cost would then win. But we know that doesn't always work. And so now there's a duty to work together, and there is there's encouragement. That's the wrong word. They are encouraged to have joint appointments and joint committees, which they may have done in the past, but it was via loopholes rather than to be official. And the competition element has been removed. It doesn't mean that an ICB can't, or commissioners can't, put something out to tender. It just means they don't have to. Okay, so if it's beneficial to the system, they put it out to tender. For example, if in my area we cannot cope, we haven't got the capacity to cope with the number of cataract operations we're doing, or then we might put a contract out to do some of the cataracts on our behalf. So there's not a big issue. So the other big thing that's happened is a bit of a tidying up of the framework. So I'm going to go back a few steps here. So NHS England, when it was all set up back in 2012, NHS England were the commissioners. Okay, and NHS Improvement didn't come about until much later. What you did have was an NHS Improvement was never a statutory body. It was never a legal entity. It was just what they called it. They had two different bodies. You had the Monitor, which looked after foundation trusts. So way back in the probably early 2000s, late 1990s, early 2000s, there was a push to give NHS trusts a bit more autonomy to be a bit more independent and a bit more autonomy. And if they could prove they could show they could be financially stable and behave themselves, then they were given this autonomy by being made into a foundation trust. And as with everything, it might have sounded good initially, but then you found out that a lot of organisations then cut a lot of corners in order to show their financial stability, and then crashed and burned soon after, and then needed propping up a bit. And so whilst initially, when this was all set up, you had Monitor, who kind of were the regulator of these foundation trusts, and then you had the Trust Development Authority, the TDA, who looked and helped organisations become foundation trusts. And then, as I said, after a few years, they realised that being a foundation trust wasn't the be-all and end-all, and some organisations were never going to be foundation trusts often because of their geography or the logistics of how they worked. So they kind of went, okay, that's not going to work. We don't really need more foundation trusts. The ones we've got, we can't take away, but we don't need any more. And what we need to do is start clawing back that independence again. So that's why Monitor and then TDA merged to become NHS Improvement. And so NHS England, the commissioners, NHS Improvement, the regulators. And then as finances got more and more tight, you had the commissioners who wanted, main focus of things on patient safety, and the regulators, which were much more about finance stuff. And they had mixed messages. And so the organisations, the trusts were going, well, who do we listen to? Do we listen to our commissioners or do we listen to our regulators? You're sending us mixed messages. And so they kind of merged around the pandemic or just before the pandemic to become NHS England and Improvement, because again, legally they had to be separate. And then what happened in this in the latest kind of legal changes was they merged. So there's one body now that looks after the NHS in England. It is called NHS England. Okay, so it's quite a long-winded way of explaining how the accountability of the organisations have changed. Okay. The other bit that's changed slightly is that there's increased power to the Secretary of State for Health and Social Care. So previously, the NHS England was arm's length. You had the chief executive of NHS England, who then got kind of a mandate every year from the Department of Health and Social Care, but there was very much a gap in that. But part of the reforms were to try and to kind of bring back some of that power and give more accountability to the Secretary of State. So I'm going to pause there. Try and stop sharing. And we're going to have some questions. So someone's already got. So how can organize? So the money they basically get loans from the Department of Health. Department of Health has a kind of contingency budget, so they don't spend all their money. They get loans, and then you pay back those loans. And so there's something, if you look at your annual accounts, you're something called PDC, public dividend capital, and that's basically your interest or your repayment on your loan that you got from the government. Now, around COVID, they wiped all the loans out, so everybody's get back to zero. Good and bad. It was great if you were an organisation that was really in debt. Not so good if you were quite well behaved and didn't have much debt, because everybody's back down to zero. But now we're accumulating again over a period of time. So any questions on put it in the chat. I'll try and see if I can see it on Slido. I can't always. See. You can shout it out. You can talk if you wish. So ICBs are replacing the CCGs. They are the commissioners now. They're the commissioning body. But CCGs were basically GP kind of led. So they had the majority of the CCGs were GPs, with some representation from the providers. ICBs have a kind of broader remit, so they have local authorities, they have the providers, that they're kind of, and primary care as well, but it's not so heavily focused on primary care. ICPs are that interaction between health and social care. So you have the ICB people. So you have your providers, your local authorities, but you might also have police. You might have some local charities that may have interests. You might have housing associations, various other people that might have an interest. Stakeholders, dare I say it, I don't like that word, but stakeholders in health and social care of a particular area. So that what it's the idea, and I would say that some areas are more developed in terms of their ICPs than others, and are more inclusive, but every area has a slightly different way of doing it. So the need for multiple layers, it is because that there's so many regional differences in how things are structured. So if we were to do everything at national level, you would probably find that you get more bias. You get bias to the big cities, you get bias to certain areas. So the requirements of somewhere like London, where high density population, versus Northumbria, are very different. And so the structures and the spread and how things are spent will be different. And so you can't have national thing. You'd have to have local things, and so you'd have to have area teams anyway. And so you can have them more within NHS England, or you can make them kind of more joined up. And the idea is that with the ICBs is that you kind of bring in a closer partnering with social care, which is completely within the local authorities. So while the Department of Health and Social Care is called that, it has actually no very little impact on social care. That's all done through the local authorities. And we all know that improving social care will potentially massively benefit the health economy. And again, it's all historical. Trusts are trusts; they're individual bodies. There was mooting, when they tried to talk about ACSs, which is basically another word for which is the accountable care systems, which is an old name for ICSs. They are basically that's what they have in America. And there was worries about it being more heading toward privatization because of that. So are the cost efficiency? Oh, hold on. Cost efficiency budget targets chosen arbitrarily? So it's based on what they feel, and it's a negotiation. Those kind of cost budget targets are a negotiation between your finance teams and your board of director, your board, and NHS England. Essentially how it's done, and you can try and reject your control total, and if you don't achieve or have nowhere near your control total, you might find your director of finance loses their job. So it's much more cutthroat than clinical medicine. And particularly in the current climate, I don't think you can say no further efficiencies can be made, because money is so tight. And I say that not from, our organisation has gone through something very similar, where we don't think we can, realistically, with the way that without massive investment to change our estates, our hospital setup, we don't think we can make any more efficiencies realistically. There's obviously small things we could do, but not big scale. So we're never going to reach our control total. And as a result, you'll find that our director of finance has lost they've been asked to move on. So yes. Is wiping out loan debt not a bit like printing more money? Yes, it is, and it isn't. So again, it depends on why. So a lot of the kind of loan debt it's all arbitrary anyway, because it's within the same. So it's all within the same system. It just gives organisations a bit more footing. So, for example, King's Health, so King's College London, the main reason they went into a massive amount of debt is because they were asked to take on 2 other poor performing trusts. So they took on Orpington and Bromley hospitals, and as because they're local, and because of, again, normally states reasons, they lost a lot of money in the first few years. So there is it's often related to that, this historic debt that they've taken on and then can't get rid of. So some of that is an issue. The knock-on effect is that overall, there's no incentive apart from, I mean, the only incentive to actually meet your control target is that you're more likely to get investment. So NHS England will more likely approve investment if you're sensible with your money. That's the bottom line. Other than that, those kind of loans and stuff are all within the same system. They're all internal loans, essentially. Trust can make money. It depends on how your payment system works, which we'll talk about in a bit. But you can, trusts make money from private. So trusts that do private work or have on-site private work. If you've got charity components, car parking, catering, all make the trust money outside of their clinical services. Some organisations have massive amounts of land. The Guys and St Thomas's have a massive amount of land. They own a lot of central London in terms of around their hospitals, which they rent out, and they money from that. So that you can get money from various different sources outside of the clinical commissioning side of things. Was that a comment? I can't hear. Okay. If there's no compulsory need for services to go out to tender, yes and no. So does this mean less opportunities? Yes. So there's no direct way potentially for privatization as such. What you'll find at the moment is that it's about capacity. So if a NHS trust doesn't want to provide a service, so the most common one at the moment is drugs and alcohol services. They don't tend to be lucrative. They tend to be a bit of a money drain, drug and alcohol services. So they're often done by social enterprises, charities. They're not done by private sector companies, but they're done by social enterprises and charities to provide that. And the other reason is where there's capacity issues. So as I said, we, with the best will in the world, we couldn't provide all our hernia care or all our some of our straightforward, high volume, low complexity. We just haven't got the capacity to do that. So we've had negotiations with the ICB, and they've then outsourced those to some of the private sector organisations. So they will get there's always some opportunity for private sector influence, but it's more controlled rather than and ideally, once those contracts run out and we've increased our capacity, we'll bring them back in-house. That's the idea anyway. Trust in deprived areas, do they get a fair slice of the pie? The bottom answer, probably not. If you look at so it's not just deprived areas, it's those that the kind of the places that are specialist hospitals. You'll find that Royal Orthopaedic, the Royal, those that do just specialist stuff will often make more money. Those with high international recognition get more money. There are some limits to what proportion of your income can be from private independent work, but the London hospitals make a lot of money for a reason, and other places outside of that struggle with that. So I wouldn't. There are, how the ICBs get funded is a kind of allocation system. It's done by population, and we'll talk about in a second. And there's various formulas, and one of those things that they're trying to build into that is deprivation indexes. But I don't know how accurate they are or how refined they are yet. There are 42 ICBs, and they represent sizes of about 0.8 to 1.2 million people, broadly speaking. So obviously in like something Northumbria where there isn't that many people, but it's a massive geographic area, you couldn't have, you can split that into multiple ICBs. So there's one there, but in London there's multiple ICBs, and Manchester there's multiple. In some other areas that are highly dense, there are a bit more ICBs. Who decides the financial targets to decide what levels of costs are acceptable? Again, a lot of that is a negotiation, and we'll come to costs and what often it's how you justify it, and we'll talk about in your business plans, because everybody wants to develop their services, expand, change, and it's how you sell your business plans and your business cases, rather than necessarily just arbitrarily cutting costs. I don't think any organization cuts costs at patient care expense knowingly. Anyway, there are the unintended consequences. So I'm going to talk about how how trust and payment systems work, because in a bit I think we'll probably take a 15-minute break, 10-minute break. Should we take 10-minute break? Because I try and space this out. I'm going to divide it to 3 sections. So we'll do NHS structure now, then we'll do payment systems, a bit about costing and coding, and then we'll do business cases at the end, and we'll have a break in between those. So if we come back in about 10 minutes, I'm just going to sit and have a coffee, but if you have any questions that you want to talk to me about, feel free. But yeah, have a wander and have a break. We'll see you in about 10 minutes.
Hi, Akiba.
Hello.
Akiba, hi, Antonio here. Silly question. What's happened with the primary care networks? Are they still what they used to be?
They're still in existence, yeah. They still so a lot more funding will be coming through the primary care networks, and again, it's all about trying to have more collaboration, and so things aren't repeated, and try and do more economies of scale, particularly because increasingly you've got obviously GP practice or GP practices are independent; they are private companies essentially, and whether they're and they're becoming multi-partner, massive, a lot of them, in order to stay afloat.
Right,
and
okay.
so the idea is that these primary care networks represent these practices on the ICBs, and they're part of that as well. So their existence, again, some are more developed than others and are more active and doing more than others. There is a lot of variety and variation between the primary care networks, and it depends on how they're split up.
Okay.
Because there's things like
I think that's okay. The other question I wanted to ask you is about these collaboratives. I'm hearing more about, especially in Devon, we're having the Southwest collaboratives. Have you heard of?
Yeah, again, they work in different ways. So some are more procurement based. So you're buying stuff together. Some are looking at different ways of working. So they're trying to look at trying to do things. Is there a way of streamlining? So it might be centralizing some stuff, but actually decentralizing other stuff within a region. So there's different types of collaboratives. The most established ones are procurement ones. So trying to get to people to buy things of a similar nature. So whether it's EPRs, patient record systems, or whether it's just equipment, if you can buy it in bulk from one group, you get cheaper. It's bottom line.
I suppose you'll cover that in this next bit. Is that
a little bit? Okay, shall we get started again? So I'm going to talk now about payment systems. And so that's basically how organizations get paid for the services they provide. Okay, this is something that changes regularly. So what we're going to start with is the building blocks. So there are 7 or 8 ways in which any organization or any body can get paid for services they provide in healthcare. And these building blocks are combined in different ways to different levels in every healthcare system in the world. Okay, because these are the basically ways of doing it. And we'll go through some of the pros and cons of them and go from there. So the first one is called a block contract. So a block contract is a fixed amount to cover a specific range of services. A true block contract, you decide, you say you're going to provide this service for me, and it doesn't actually matter what you provide in terms of the amount or the quality. Often there are some quality kind of requirements in there, but in terms of quantity, certainly not. And so that's the basis of the contract. The benefit of a block contract is it's predictable. The commissioner knows how much they're paying, and that's it. They know that's a fixed amount. The provider knows how much they're receiving. But the problem is that if, for example, and it doesn't matter what demand or supply. So if you, as a provider, under deliver, So, say, there's a need for X number of hip replacements or X number of, community visits, and you don't provide that, there's no penal. You don't get penalised. So the commission loses out. If you over deliver, so you do more than is required, and then you were budgeting for, then you don't get any more money. So it's predictable, but it doesn't depend on it doesn't change with demand or supply. So it's really useful for times where money's really tight, or it's really hard to predict or measure the activity levels. So traditionally, it's used in community services, and it has been used in mental health. It was obviously used during the pandemic time when it was really unpredictable to know what kind of activity levels we'd be seeing. So that's block contract. And in the kind of few years before before pandemic, a lot of acute organisations have shifted towards that because money was so tight, and it was the only way of ensuring that you didn't go over budget. The commissioners didn't go over budget by having a block contract because it was all predictable. So that's a block contract. Capitation is basically a per person payment. Okay, it's how ICBs get their money. It's how the bulk of GP is funded now, and it's also how health boards in Scotland and Wales are funded. They're by capitation, so they get a allocation based on the size and complexity of their population. The kind of caveats or the issues is to how it's weighted. It's a weighted population. So the population, you get X number, and then you change it based on various factors. Now that can be age, it can be deprivation, it can be need, and it's weighted in different ways. Now, all the controversies around capitation are around the weighting systems. So there's something called the Cahill formula, which is what's used for the kind of global sum payment in GP services, primary care. And that weights you on various factors, deprivation, age of the population, and something about need. So that is probably going to be used increasingly. As I said, it's how ICBs are funded as well. And again, there's a weighting, but they probably haven't quite fine-tuned the weighting system properly yet. And it will probably change over time to kind of, as we get better at identifying the impact of deprivation, the impact of age, the impact of socioeconomic status, and rural and urban differences. Oh, it's gone. That's why capitation will probably change in different ways, but it's all to do with weighting. Okay. Pathway of care is it's currently gone out of favour, but these things seem to go in and out of favour quite quickly. So pathway care is currently out of favour, but it was basically a single payment to cover a whole pathway. Okay, so the commissioners would pay a lead provider a payment to cover the whole pathway of care. It was used in maternity services until the pandemic, essentially. And what happened is you got a payment for your antenatal care, you got payment for intrapartum care, and you got payment for postnatal care. And your lead provider then could kind of outsource that. So you might have the antenatal, some of the antenatal care, the home visits by midwives, done by the community organisation, and in different ways doing it. The problem was that you had different complexity. So, for example, for antenatal care, you had low risk, medium risk, high risk. For intrapartum, you had 5 different levels, and you had 3 for postnatal in terms of the needs. But once you were started on one bit of the pathway, you didn't get any more payment, any more money if you went up a level. So if you started off as a low risk pregnancy, and then you develop complications and need more scans and more appointments, the commissioners wouldn't give you any more money because it was started off as low risk. You get more money for the intrapartum, you go up a level for that, but you missed out. And so it was thought not to be that efficient. and not a good way of doing it. They have mooted it for things like elective joint replacement, where you from referral to kind of optimization, prehabilitation, the operation, and then rehabilitation all being covered as one pathway. It's not come about yet, but it might do in the future. So pay for performance is part of all contracts generally. It's just has different value or different weighting. So in GP, in primary care, it's part of the quality for outcomes framework, and that can generate up to 20% of your income, getting these quality of outcomes, achieving different points. In the kind of acute community mental health services, it's the sequins, it's the commissioning for quality and innovation. Now, and you get national sequins and you get local sequins. They were, when they were first set up, worth 2.5% of your contract value, which is a significant amount. Now they're worth a bit less now, they're worth 1.25%. And the reasons for that are twofold. So obviously you want to have quality kind of markers and encourage people to incentivize quality care. But what was happening is that organizations would implement a particular innovation to improve quality for that year to achieve that sequin, but then they'd have the ongoing cost of doing it without necessarily that money coming in. And because they would change every year, it was also you're always constantly trying to get that money and not always achieving it. So it's gone down. It's still a part of it, but the weighting's less. Per diem is not really used very much in this country. It's used in other parts of the world a lot more, but it's a lump sum payment per patient per day of care, and you can do it by level 1, level 2, level 3 care kind of days of care. So in some parts of Europe and some parts of the other parts of the world, you get payments per patient at level 1, level 0, level 2, level 3 care. The one that we're probably most familiar with these days is the activity-based payments. It's basically incentivized to do more. The more you do, the more money you get. And it's also it's been called payment by results in the past. It's basically a national tariff payment system. And when it first came out, it was really good at driving down the elective waiting list because organizations were incentivized to get it down. However, it was never very good at dealing with the emergency and urgent care side of things. So during that period of time, any organization that did just elective work, they were fine. But organizations that did any kind of emergency or urgent work really struggled. And so it's kind of now in there, but it's kind of has a reduced impact, and we'll talk about how it's being implemented at the moment. The case base is based on your coding. So the coders take into account diagnosis, treatments, so any procedures and patient comorbidities, and it goes into basically a computer program that comes out with a healthcare resource group, which is what the tariff is based on. And then finally, you've got something called pass-through payments, which are where the cost of delivery is paid by the commissioning body. It's normally for either very expensive stuff or very specialist stuff. So high-cost chemotherapy drugs are part of that. So whatever it costs you to deliver the high-cost chemotherapy drug, you get reimbursed for. Okay. So every few years, we change how the NHS payment system works. Currently, we've got something called the Aligned Payment Incentive System. And this is basically a blended payment system. And I think in future, there will all be blended payment systems, but will be a blend of different versions of those building blocks. So this is used for all payment systems, so acute, mental health, community, and ambulance services are all under this Aligned Payment Incentive System. And what it basically contains is the majority of your money is from your fixed element. So that includes an agreed level of acute care. Oh, this is for anywhere that does any combination of acute and elective care. So the fixed element is any agreed level of acute activity, and that includes mental health, maternity, community, and ambulance services. BPT is your best practice tariff. So that's part of the case-based system where if you there's the one tariff for delivering the service, but if you achieve certain quality markers, there's certain kind of key things you've got to achieve, then you get paid a higher rate for each individual patient across the board. And so that's probably a better way of doing it, but it's your fixed element includes you achieving that. Okay. It includes things like any chargeable overseas visitors, your clinical negligence scheme trust contributions, and any services and drugs delivered by the kind of home delivery service. That's where the social care and NHS kind of overlap a little bit more. So that's in your fixed element. Okay. And you negotiate your fixed element based on your previous budgets, essentially. So you say, this is how much we've done in the past year, and the commissions go, okay, that's how much we'll pay for this year, and you negotiate that. And then you have your variable element, and this is the kind of incentive to do more. So if you just had a fixed element, just had a kind of a fixed contract, and it was just your agreed level, there's no incentive to do more to drive down the waiting lists. So they've got this variable element, which is for elective care. So elective, ordinary, and day case stuff, outpatient procedures with a NHS payment system unit price. So certain procedures that are carried out as outpatient in the outpatient departments have a tariff associated with them. Okay, and so that's in the elective bit. Your first attendances at outpatients, and then certain extra imaging and nuclear medicine stuff and chemotherapy delivery is all included in the variable. So you get extra money for that. Okay, so that's the main. That's getting the next biggest bulk. Okay, and obviously, if you having included the best practice tariff and sequins in there, you obviously will lose money a little bit from the variable element if you don't achieve it. Okay, so that's the bulk of your income. Now, there's something called low volume activity contracts. So normally that's for visitors. So people who are from out of area. So somebody who holidays in somebody from Cornwall or holidays in Northumbria, because that doesn't happen very often, and the value of the number of people that do that is probably quite low. You'll probably find that that's a low volume contract. So that's done on a separate contract. It doesn't have all this kind of detail in it. It's much more of a negotiated kind of tariff-based or fixed element to a contract. But it's a very small amount of any organization's income, these low volume activities. Okay, so that's the aligned payment incentive process. So we had it last year, so from 23 to 24. We've got it from 24 to 25. We always knew that. What we don't know is what we're going to do from 25 to 26 yet. And there's multiple reasons for that, because then seeing how this goes, there'll be election, there'll be new I think whatever happens, there'll be a new some sort of setup of government, and there might be a new health secretary. So a lot of this, and potentially a new chancellor. So a lot of this will depend on what happens with the elections. But we know that this is probably the direction of travel. So we talked a bit about coding and how that underpins some of the income you get. So, but before we go into that, we have to kind of work out the differences between cost and price. So cost is how much it costs you to deliver a service. Okay. And the price is how much you get paid for delivering that service. In most cases, in the private sector, in the cost of making or buying bulk buying Mars bars and the cost of selling it individually, you want to make a profit, okay, and at least break even. And in the NHS, we want to break even. We're not necessarily trying to make a profit. But what you'll often find is that in inefficient systems, And this is where you can do your kind of analysis and try and do your pathway improvement and all that kind of stuff. There may be situations where the cost of delivering that service is more expensive or costs more than the amount you're going to get for delivering that service, particularly if you're, doing it in an efficient way. And then it goes back to how those prices are set. Those prices are set generally by taking an average of everybody's, so once a year, there's a submission of all how much it costs you to deliver each service that you provide, divide down to HRG codes. And then they take an average of that cost. And so in theory, it's possible to deliver that service within that cost. But if you're not doing that, then there's something wrong with your service. And it might be that you're providing, it might be a coding error, most commonly some sort of documentation or coding error. It might be that your service is either there's aspects of that service that have not been factored in and doesn't get accounted for, or there are specific quirks to your service that means that's why there's a specific cost to it, increasing cost. It might be to do with how you have to deliver it. But that's where your kind of opportunity is. Okay. So I'm going to show you this video on clinical coding. We'll then stop for a few questions and I'll talk about how you make the best out of your costing.
This animation will give an overview of clinical coding in the NHS. Essentially, clinical coding is the way an NHS organisation records information on what care is given to their patients. It is the translation of the patient record into coded data. It is usually done after the patient has been discharged, and there are strict deadlines that need to be adhered to for data submission. So how does clinical coding work? A patient's hospital stay, from the point of admission to discharge, is called a spell. During their stay, a patient may be under the care of different consultants. This may be due to a change in shift, ward, or speciality. The time period under each consultant is called a finished consultant episode, FCE, or episode of care. So a spell can be made up of a single or multiple FCEs. Clinical coders code diagnoses, comorbidities, complications, and any procedures undertaken for each FCE. So how do we get from treatment to coded episode? All care delivered during a patient episode is documented in the patient notes. Once the episode is complete, the notes are sent to clinical coding, where trained clinical coders carefully read through the notes and allocate the appropriate alphanumeric codes. For diagnoses, they use the International Classification of Diseases 10th edition, ICD-10, which comprises over 16,000 codes. And for procedures and operations, the OPCS Classification of Interventions and Procedures version 4.9, which has over 4,000 codes for procedures and operations. The codes are entered in computer software which determines the Healthcare Resource Group, HRG. Most, but not all HRGs have an associated tariff. An example of this: clinical coders are like detectives, investigating all aspects of their journey from start to finish. You begin by reviewing the documentation, physical and/or digital, for the stay. For example, an elderly woman who had a hip operation 2 days ago. From her medical notes, you find out the main condition being treated, any relevant comorbidities, and the procedure performed. Then, utilizing the ICD-10 and OPCS procedure classifications, you find and assign the special alphanumeric codes and record these into the organization's patient administration system. This coded data can be understood throughout the NHS and beyond, and used to plan for future patient care. What are healthcare resource groups, or HRGs? A healthcare resource group, HRG, is a grouping of diagnoses and/or procedures which are similar in terms of care delivered and the resource used. In order to reflect the complexity of care delivered, HRGs capture main condition treated, investigated, procedures, investigations performed, comorbidities, complications, age, length of stay. Healthcare resource groups offer organisations the ability to understand their activity in terms of the type of patients they care for and the treatments they undertake. Why is clinical coding so important? Clinical coding provides the information that underpins almost all the data flows within the hospital. It can be used for clinical governance, quality improvement, epidemiology, benchmarking, commissioning, financial flows. The challenge. Coders are only able to use information that has been documented in the clinical notes. Incomplete or unclear documentation has been repeatedly shown as a weak link in the data quality chain. Now we know how important accurate clinical coding is to NHS organisations. Here are some top coding tips. Clear. Write clearly and legibly, type if possible. Use appropriate language. Check with your organisation, as some have agreements to accept certain terms. Complete. Ensure all diagnoses and procedures are recorded in detail. Document all relevant comorbidities. Understandable. Abbreviations and shorthand cannot be coded. Coders are not allowed to interpret investigations or numbers. Accessible. Make sure the coding team know where key information is recorded.
What do you need?
Okay, I'm going to stop there again. Okay. So I'm going to quickly just go through a couple of caveats to that video. So often coding in the emergency department is slightly different because they go through a different data set. They call it emergency care data set, and it's coded directly from. They don't have a coding system that does it behind the doors. It's done directly at point by the clinicians, whatever clinicians put into the system. GPs, obviously, primary care, they code themselves as well. And part of the problem is that when they moved from paper to electronic systems, they got kind of most commonly medical students to try and transcribe it, and the accuracy of the coding within that system is quite poor, and probably is not as robust as it could have been. And finally, there are caveats. Organizations have caveats and workarounds to try and include things like, so I think in my organization, we accept the question mark on our EPR system, but not in the paper notes. And we also accept impression as of last year as our working diagnosis. Okay, so there may be some caveats and some discussions that you've had in the systems. Variable elements, just going through some questions. Variable element centers are given to the trust. So that's into the trusts, but then they often then feed downwards, depending on your depending how your organizations are structured. For example, in my organization, the anaesthetic department runs very separately to the surgical department. So us doing more activity costs us more because we've got more staff costs, but we as the anaesthetic department don't get more money from the increased number of activity, because that goes to the surgical teams. Okay. But we know we have to do it. So they're given to the trust overall. Drugs and alcohol services, they don't appear to me. I don't know the details of that. They are run under the NHS, so it's paid for by the NHS, but in a lot of areas, not all, in a lot of areas, there are social enterprises that can do it, charities that do it better, or are more willing to do it than the community mental health trusts, because they're the ones that often do it. I'm not sure it's more lucrative enough. It's just capacity issues as well. But it will vary depending on your area. Any other questions on the payment systems and coding? Because often that generates you. The rules are so something's put a question on Slido. So that regarding clinical coding, there seems to be rules regarding what they're allowed to code. Why they have these rules? They're data interpretation rules. So they are not trained to interpret data in a certain way. And so things like abbreviations can mean different things to different people, and they have they're not allowed to interpret it in that way. Yeah, it's all about making sure the data is accurate as possible. Increasingly, what most places are trying to do is incorporate SNOMED coding, which is a certain way of nomenclature terminology that we as clinicians understand, because what the coders, their HRG groups and all that kind of stuff are very different from the clinical notation. If we do SNOMED coding, then it's more accurate, and for the purposes of our quality improvement, our data analysis, that's a more accurate way of doing it rather than using the coded data. So a lot of places in their EPRs are trying to use SNOMED coding, SNOMED terminology as mandatory in your kind of main fields, your diagnosis fields and treatment fields, so that we can do that. I don't know why we're not using ICD 11. This comes down in various batches from NHS England and the data team there. Are there payment schemes which incentivize environmental targets? Not at the moment. There is a requirement that NHS has to be net zero by 2030, I think it is, but there's no money behind it per se. So radiology is, so again, a lot of radiology, especially the urgent care bit, is part of the fixed element. So you're not on a block contract as such, you're on the fixed element of the aligned payment center process, but you do get extra funding for certain other diagnostic imaging. So it's a bit of both. And palliative care is normally probably on a block contract. And it will vary by region as to if it's changed with the ICBs, but generally not. So as we get better at inputting data into EPR systems, and as we go more and more onto digital, and the robustness of our data quality improves, then coders will probably have a different role. Their roles will change. We'll still need them, but they'll be there to check the coding rather than, because it'll be automated, and they'll be there just to check things rather than to kind of do it. Whether coders go through the entire medical record or just the discharge summary will depend on how they're working. So for us, they were going through the entire medical record pre-COVID, but then there was a massive shift to working from home, and now they just use we're in a hybrid system where we have a little bit on our EPR, but our EPR is not fully developed yet, so we still use bulk of our stuff is on paper, and they don't use up any paper resources. They just use what's on the digital system. So that's the problem. Investigation. So this is back to radiology, I'm guessing. So the fixed element will be based on activity from the previous year and any potential predicted increases, and then your extra diagnostics imaging will be coded separately. So HONOS and care clustering is a different way of doing the HRG code. So the tariff is based on the HONOS and care clustering rather than ICD, because it's just a different way of doing it. Again, it's trying to allocate funding according to to a smaller number rather than the full ICD 10 or 11. And there you go, ICD 11 is coming soon. Yes, the coding process is different for done in outpatients because outpatients are not normally coded, so you have to make sure that it's recorded somewhere. We don't know about any penalties for not being net zero. It depends on the government stance at that time. There isn't anything in the system yet about penalties yet, because it depends on what classifies what's within the NHS's remit and what's not. Yeah, so the income goes to the parent team and department, and then you have to negotiate a payment from within internal payment. That last question. I hope that all makes sense. Right. So going on to how we actually, okay, we've got, and we'll have another break soon. How we look at PLIX data. So PLIX data is a new way of looking at the costs that we generate. And you've got more data about this in your handouts than I'm going to go through, but essentially costing and is how it's trying to work out how we where we spend the money, essentially. So you have your resources, you have your activity, and it's linking the costs, so the resources to the activity. That's basically what it is. And so you have your patient-facing costs, you have your kind of generic costs, which are then divided out, and you get, we don't bill our patients, but in theory you get a patient bill, so you get an idea of the cost of a interaction with a patient. Okay, so and different organizations have different degrees of accuracy, okay, because they do it in different ways and they have different levels, depth of data. So generally, the easiest pathways to measure are the simple pathways, which are things like surgical pathways, because it's much easier to kind of measure a day case pathway than it is to try and measure how many interactions a ward costs. Okay, so basically how they often do it with ward costs is dividing up the kind of how many days you spent, how much the ward costs to run each day, and dividing it by how many patients are on a ward, and each patient gets allocated a proportion of that day's costs. Drug costs can be done much more accurately, particularly if you've got some sort of electronic prescribing systems. Again, pathology and radiology, if you've got electronic systems, they feed into that, and so you can get the costs of delivering that. And 9 times out of 10, any trips to theatre be the most expensive part of a patient's stay. But the idea is you get this, and one of the things you've got to do when you first kind of look at the data is to make sure it's accurate. You look at whether the data has been coded accurately, whether it's been recorded accurately. Okay, so what you'll find is, and if you do, one of the costing teams at a lot of places do an amazing job at can show you the data, and you go, yeah, but that's not right, that's not right, that's not right. And so before you can actually use the data to make changes, you need to make sure you validate the data, because they can only go by what data you've given them. And so you can do this in different ways. So and different people do, and different organizations have different ways of dividing up their costs. And person allocation example, okay, so you can use the job plan to divide up how they've spent their work, and then you can divide that up, and then you can use things like weighted length of stay, how long how much time cutting time you've had, how many patients discussed per meeting, how many weighted attendance. You know, some patients may be longer than others, and so that's how you then divide up the costs. You can use PLIX data in lots of different ways. From our point of view, and I'm not going to talk about the finance side of things because that you can do that. That's for the finance teams. But what we can do is we can look at pathway redesign. So you can use this in your business cases. You can show how by changing the pathway you can save costs. Okay, and with your service redesign and reconfiguration, and you can work out then if your pathway design is going to cost you more. Okay, and if you can show it. It's a good way of showing how the benefits of your whatever change you're going to make. Okay, it's also useful things like the national metrics like theatre utilisation and achieving, you know, outpatient attendances and that kind of stuff. And you can show, and it's also used for benchmarking. So there are a couple of examples in the pack. This is one of the best ones that there is. Where you can use PLIX data to look at two procedures. This is in prostates. One was this Urolift, which is versus a TURP. The TURP often was an inpatient stay and often had a relatively high rate of complications, and you need to be in for 1 to 2 days. Whereas Urolift, whilst it's more expensive because the consumables cost more, because it's a day case and it can be done in less time, so you can do more cases per day, it shows a massive difference in the cost of delivering that service. So whilst the Urolift is a more expensive procedure, it has overall is more beneficial, and you can use your PLIX data to show that. There's also a national PLIX portal that's been launched recently where you can compare your data if it's on there. This is Manchester's data. I've stolen these from a colleague in Manchester, one of the costing teams from Manchester. And this is their data and shows how they look at for a particular value metric, and you can get real granular data. Unfortunately, there are some places that, like Leicester, where how the national data has been interpreted versus how we've submitted it doesn't quite align. So our data has been excluded from this, which is annoying. But it is a very useful way of saying, okay, why does it cost us more than to deliver this service than it costs the best places? Is it because of patient population issues, and we're doing slightly different types of people, or is it because of how our service is, and is how, you know, or are we doing a different technique? And can we do this more, you know, a slightly different technique to do it, or do we see patients too many times in our pathway? There's all kinds of ways it could be looked at. But I'm not going to concentrate too much on PLIX because it is something that you need to look at in your own services. Again, so that is a whistle-stop tour of PLIX, because again, I just want to touch on it and get you introduced to it, and you can contact your own organisations to look at it rather than focusing on it, because I think I want to make sure we allow enough time for the business case section. So your trusts PLIX data you can get from your PLIX team. Every organisation has to have a PLIX team, which sits normally within the finance department, and you can get it from them. There is a portal. There's a PLIX portal that NHS England have, that you can ask for access to. As long as you've got an NHS email address, you can look at it to compare it to others. But they may be able to, the PLIX teams may be able to give you that data anyway. So rather than, you know, traipsing around, and it can be quite hard to get a grip on, because you have to know the right HRGs for your specialities and all that kind of stuff to be able to analyze it properly. But liaise with your PLIX team because it's always worth seeing before you try and compare it with others, is looking at how your data has been collected to make sure it's been validated properly. Okay. Any other questions before we have another probably another 10-minute break, and I will then finish off with trying to put it all together with business cases, and hopefully making it all come to light and make it all relevant again. I appreciate this is not the most exhilarating of subjects and topics. No, well, I'll stay. I'm gonna probably make a cup of coffee to keep myself awake, and then I'll see you back in 10 minutes. I'll be here if you have any questions. I'll try and keep answering them as we go along. But I think an hour of listening to me waffle on is probably too much. So give you a 10-minute break. Come back. We'll talk business cases. Right. Before I move on to business cases, I'll just try and answer some of the questions in the chat. Any resources for model PLICs of different specialty areas? It kind of depends. So the best thing I would suggest is a look at the dashboards. So you can get to the dashboards by it's one of the apps within the model health system on NHS. If I show you how it works, so if you basically you can, if you log into the, I'll put the link on the in the chat, but there's a link to the apps.model.nhs.uk. There we go, apps.model.nhs.uk. You log in there and you get access to, you can request access to lots and lots of different dashboards. There are so many different dashboards that will cover different areas. I mean, I'm not sure the flood risk toolkit's that useful for most of us, but there's the greener NHS dashboard that tells you some of your green stuff. You've got your ICB PLICS benchmarking tool. You've got your model health system. And then down here, you've got your data quality, your PLICS data quality dashboard and your PLICS integrated dashboard. And you can just request access to that by registering with the system. So that's one way of looking at it. In terms of Andrew's question about is it too complicated, it depends on what you're trying to achieve. Okay, so in terms of, it's not useful in terms of income, it's in terms of useful costs. So you can see if a cost of a particular pathway procedure, so say an appendix or a a particular operation, you can see if that's costing you more as a whole compared to other areas, and rather than whether we're being paid enough. Whether the paid enough bit is an internal thing about whether the surgical specialties are paying you enough. You can try. I think that often you'll find it difficult to. I've been trying for 4 or 5 years to try and get theatres to be paid based on how much it costs us to deliver a service, rather than an arbitrary number based on session counts. But I've been that part of the problem is we've been through 4 directors of finance at that time. So yes, it's not too complicated or beyond your remit. It's just you've got to slightly change what you're looking for. So reducing the cost rather than increasing the income. Right, back to business cases. So what is a business case? So what is the purpose of business case? Not had some interactivity for a bit, so what's the purpose of a business case? What do people think? So I think most people have got in the right ballpark. So it's about two things really. It's about, if you need to develop your service, whatever it is, then what you want to just try and get an allocation of money. Fair enough, and you have to try and justify that. But it's also about how you've chosen and decided your chosen solution. So in terms of that way, yes, it's about see if your service not only if it's cost effective, but whether it's worth the money it's giving. So you have to justify your rationale for it, but also and compared with all the other kind of pulls for money. But also it's about how you've come up with the solution. Okay, so the drivers of a business case are twofold. Okay, so the main number one reason for driving a business case that is to solve a problem. 90% of business cases that fail, I would say, are overly focused on a solution. So the whole business case is written around a solution. You've got this solution in mind, or you've got whatever you want to do in mind, and that's your kind of your focus. You get tunnel vision almost, because that's your kind of driver. And what you really need to do is your business case needs to be about solving the problem, and then thinking widely, and then narrowing it down to your final solution. Okay. That's where most business cases fail. You need to solve a problem. Okay. Historically, when money was a bit more, when the payment system and money was a bit more allowed, and then the payment and the money was more, there was a lot of business cases were written to drive more income. I don't think that necessarily kind of works anymore. But what you can do is improve quality. But you've got to show you've got to justify that improvement in quality over over the cost of it. Okay. But most business cases are to solve a problem. Okay. What you also need to do is try and understand what the process within your organization is. So a lot of the time, I within my department have to then talk to my so even though I'm the head of service for anaesthetics at my site, we're a multi-site trust, so therefore I've got to submit and get the clinical director on board, who then has to also get other people on board to kind of submit the business case and then get it approved. So you have to understand how many hoops you have to jump through, who needs to be able to see it, in terms of who you're going to present it to, who you're trying to get money from. And I'll talk about that in a bit. Oh, I missed a minute. Okay, so in terms of what needs to be in a business case, it's the who, what, where, how, when, why, all the kind of the questions need to be answered within the business case. And there is a structure that's recommended. There's something called a 5-case model. And there's links to the kind of official stuff at the bottom of the slide deck. So the 5-case model is something that was designed probably 20-30 years ago by the Treasury. It's the broad mechanism by which all public sector business cases should be written by. And there's a lot of overlap between the private sector business plans. So if you were to write a business plan in the private sector, it's very similar. The concepts behind it are very similar. Now, there are courses, there are all kinds of things you can do to try and get you a heads up on this stuff. I would say it's not worth it. Because a lot of the courses, there's a Better Business Cases course, are designed for people who do business cases all day, every day, and do kind of high, big spending business cases all day, every day, rather than the smaller things that we will probably be more involved in. But to broadly cover the 5 cases, there's strategic case, where you're justifying why you want to do what you want to do, showing its value for money, there's how you're going to do the commercial side of things, so the contracts, there's the funding around it, and then how you're going to manage it. And we're going to go through these in a bit more detail. What I'm going to concentrate on are the strategic case and a bit about the management case and a little bit about the economic case, because they're the three areas we as clinicians are most interested in and have most involvement in. The other bits you probably need to get other people involved in to try and give you advice. But I'll touch on some of the key components of those as we go along. I'm not going to miss that one out because I've already given you that. So this is the main slide that shows you what needs to be in each bit. And we're going to go through these in a bit more detail. So in the strategic case, it's your context. It's how whatever you're trying to, your problem or your why is it a problem, and how does that align to the organization's aims and ambitions? So your organization will have some sort of annual plan or some sort of target of what they want to achieve in a year or in the next few years, and you have to somehow, and it might require some creative writing, align what you're trying to do with the organization's aims and ambitions. Okay, because if it's either negatively impacting it or not really relevant to it, it'll get dismissed very early on in the process. So you need to show early on how this fits into the organization's broader plans. And it's not, normally you can pull it together and most, by improving something or reducing costs, you can do that. Okay. The next bit is all about making the case for change. So you put your current context in, what's currently occurring, how your service is set up at the moment, and then you put in your case for change. And this is where you need to have evidence. You can't just say we need this because we're rubbish at this. You've got to have the evidence. Now, this is where benchmarking data, so whether it's from the Clicks dashboard, whether it's from any of the model hospital kind of dashboards that there are, or any of these other dashboards that are on there, whether you've got benchmarking data that you've accumulated yourself from other hospitals or other organizations, whether it's a CQC, the Care Quality Commission report that says you need to do better at this. That's quite a big driver. They're getting it right first time, the GIRFT. They often want, this, that, and the other in their requirements. The model hospital has good analysis and is a decent driver. The NICE and Royal College recommendations are probably the least effective drivers. Yes, they are important, particularly if you want, some sort of accreditation and your hospital is or your organisation has backed that, then you can use it. But you've got to remember that every Royal College will bring out multiple recommendations out every year, and it will cost an absolute fortune if every organisation had to achieve all those recommendations immediately. So whilst it will get you on the list, it may not prioritise you enough. The NICE and Royal College recommendations. Mortality reviews and root cause analysis are also good drivers for change as well. So you need to make sure, this is where the Dragon's Den bit comes in, where you're trying to sell it and you've got to show there's a problem that needs addressing. So using, this is for model hospital. Again, I apologise if these are all surgical anaesthetic related, but this is where the stuff that I've used. So this is about us back in 2021. We were a very high user of desflurane, bad drug, bad for the environment, and there was a national kind of drive to cut it down. So we use this graph and to put a business case in to get more pumps, so syringe drivers for TIVA, so total intravenous anaesthesia, which is an alternative to using gases and more environmentally friendly. But it was just using the data to show that you're an outlier compared with the national data to drive what you want to do. Again, another one, this is to do with emergency appendectomies. So our length of stay of 2 days, we're the black line, so we're really bad, or black or grey line, yeah, black line. So we're really bad, we're not really good at that. And it's not because our surgeons can't do an appendectomy, it's because we haven't got the emergency capacity. And often patients are waiting 1 to 2 days before they actually have the operation, let alone having a length of stay of less than 2 days. So you can use that to justify increases in your emergency capacity. Okay, so this is showing you the problem. You know, rather than just saying, well, we've got multiple people waiting for X amount of time, and this is our, we've often got 20 hours of operating every day. You can go, look, compare with the national average, we're rubbish. And if you look at, and you can then put more data to go, this is all because, a number of, you can use PLIX data. PLIX data is really good at going, because theatre costs are normally the peak of an emergency appendicectomy. Costs wise, you can say this is the day that they got operated on, and this is the day they were admitted, and you can get the data. And we did that, and we got some more funding for increasing our emergency capacity. Okay. Ooh. So you've made your case for change. We talked a little bit about your existing arrangements. Okay, so what your current situation is. Your business needs current and future are about your activity levels. So looking at how your activity might change in the next 2 to 3 years. Because what you don't want to do is put a business case in now and have to do one next year because you've just increased your activity and you haven't factored that in. So you need to factor in how much your workload is going to increase, or your likely workload is going to increase in the next 3 to 4 years, if you can. Well, you can predict it a little bit based on how things have changed. So, and I'll show you that in a second. What your spending objectives are, and that links in with your scope. So scope is what's going to limit you. Okay. So in terms of, if I want to increase my emergency capacity, my business case, this business case that we're going to write, is not about building more theatres, because that's a whole different story. Okay, because that's a different thing. So we're going to be looking at just increasing the time of our theatres. Okay, rather than trying to build a whole new complex. Okay, so potential scope is what you're limited to, and the most things that are going to limit your potential scope are your constraints, which are 99% of the time just your states. Okay, so either estates or staffing, they're the biggest constraints. So constraints are what's going to limit your scope, and ours is theatre capacity. We haven't got enough theatres to have an unlimited number of theatres running, and we know there's not enough capital funding for a new theatre. So what we're going to try and do is within our remit, try and expand our theatre funding, and the spending objective is on staffing because the theatres are there. Okay, dependencies are, so that's what constraints are, limitations. Dependencies is where one business case is dependent on another business case. So if you've got a capital project, so if you're building a day case hub for orthopedics, for example, or you're building a some sort of inpatient mental health unit, or you're doing some assertive outreach, you need to do some sort of staffing. So you might have one for the building of the orthopedic day case centre, but you might need another one for radiographers, because they're under a different department and under a different thing. So, but they're linked. There's no point having a orthopedic hub without radiographers. It just wouldn't work. So that's where your dependencies come in. Okay. And then we're talking about benefits and risks. So risks are things that potentially could happen. Benefits are what are potential good things. And then there's a word called that I'd never heard of until we were doing this business cases, is disbenefits. And that's things that potentially negatives, things that could happen. Okay, so it's not a risk because it's a potential thing, but a disbenefit is something that's almost certain to happen, but it's not. It's a negative thing, and you've got to try and mitigate both the disbenefits and the risks. So, to give you an example, one of the things I used to do is run a kind of Dragon's Den type thing where people used to pitch me business case ideas, and we'd kind of go through them and interrogate them in different ways. And a radiologist pitched an idea of they have a breast cancer screening program, and instead of mammograms, they wanted to do something where they inject dye. It's supposed to be more specific and sensitive, but it requires somebody to put cannulas in. But also, because the process takes longer, it will reduce the number of patients that can be seen in any one session. So unless you factor that in to your business case and say, look, we know that there'll be less people seen per session, we then have to run either extended sessions or more sessions, that will be a massive disbenefit, because you're then increasing the waiting list and delaying people's screening. Okay, so anything that negatively impacts one of the key performance targets is always going to be a disbenefit. Okay. So we talked about trying to assess your needs, current and future. If we're just doing a ballpark for radiology, I mean, this was taken off a radiology business case that I found on the internet. So if you know that you're going to be, you've noticed that over the past how many years, last year, the number of CT scans or number of imaging that you've doing is increased by X%, and you can forecast, you're predicting that over the next 2 years it's going to increase by 2% as a ballpark. Okay, so you can have an idea of how much that is. Then you can look at how many lists that you might need to do that. Okay, so over the next how many months and years, how many additional lists you need, and how many number of patients you might need to do that. Okay, and then you can work out. And the bit in the grey was used on their business case at a time when it was all part of national tariff. So depending on the payment system, depends on whether that bit's relevant or not. Okay, but you can look at your demand and capacity modeling to look at how much you're likely to need, and then go by and try and then work out your staffing arrangements accordingly. Whether there's a benefit financially will depend on the payment system, and that's a bit more complicated. So the economic case is all about how you've chosen the solution that you've chosen. Okay, so what you need to do is think of your long list. Your long list is all the potential solutions to your problem. Now, what I would say is, when we come up with solutions as clinicians, okay, we exclude the ones that are clearly unsuitable, because we know they're unsuitable. But if you're an external person who has which most of the people who are going to be looking at this business case will be, these are going to be people who are in a completely different field, or even non-clinicians. You've got to think of all the things that they might think of as a potential solution and go, these are the potential options, and this is why we're not doing, why they're not achievable, or why we're not doing them. Okay, and then you have to have your assessment criteria, how you're going to judge those long lists to create a short list. Okay, and generally it's your desirable. You know, if you think about your job descriptions, if you've seen any job descriptions, whether it's for any kind of post, CT post, ST post, you have, or any kind of you have your essential criteria, then you have your desirable criteria. Okay, your critical success factors, your essential criteria, then you have your desirable criteria, and then you get to shortlist. Okay, and ultimately what you need is a shortlist that includes probably 3 options minimum. Okay, and it must include a kind of minimum options of doing as little as possible, to show what would it be like if you did nothing or did very little versus what you want to achieve. Okay. And then the economic appraisal is basically what your qualitative benefits. So what improvements in quality you're going to see for each option, and what's the rough cost, just so you get an idea of how you're going to, before you choose the final one. Okay, and so you can weigh them up. Okay, now for sometimes it's very hard to choose and come up with different solutions. So one of the ways you can do this is doing this kind of option appraisal. So because you know we have a broad range of specialities here, and I don't want it to all be surgical anesthetics, what we're going to try and do is use a completely different one to do this option appraisal. So we're going to use increasing. There's the problem for this business case, but we're going to use is there's insufficient capacity on the rail lines between London and the north. Okay, so that's your problem. So your scope, what can you do? So your minimum option, okay, is to increase the capacity between London and Birmingham. Your intermediate option is to increase capacity between London, Birmingham, and then from Birmingham to the northwest. And then your maximum capacity, maximum option is to between London, Birmingham, the northwest, and up to Yorkshire or the northeast. Okay, so they're your different options. The solution is how it's going to be done. How are you going to solve the problem? So the minimum would be to refurbish the existing tracks to increase the capacity. The maximum is to build a whole new set of tracks. And the intermediate is to do a combination of both. Okay. The who is, in the context of this, is whether it's a local contractor, a national contractor, or an international contractor. For clinical purposes, it's often what combination of staffing do you need? Okay, what's your minimum staffing level? What's your maximum staffing level? So your minimum staffing level for, let's say, a clinic would be a consultant. Okay, the maximum might be a whole MDT approach where you have multiple specialities and a nurse specialist all involved in a one-stop clinic. Okay, an intermediate would be somewhere in between. Okay. So who is about how you're going to deliver that service. The when is how you're going to roll it out. So are you going to just do, so in this context, it's, are you going to do London to Birmingham first and then do the second stage and then third stage? You do all in one go, or you're going to do, you know, 2 bits of it first and 1 bit of it. Okay, so you can do it that way. Funding is normally less relevant for clinical matters, mainly because there aren't that many sources of funding out there. But in this context of the rail thing, it can be completely governmentally funded, it can be completely private funded, or it can be a mixture of both. For the NHS, it can be either be, you know, you might get some ICB funding, you might get some internal funding, you might be using educational funds, you might be doing a combination of the two. Okay, so that's how you can broadly think. If you're struggling to come up with an options appraisal, this is how you can do it. And what you do is then with this, you have all your different options and you go, these are unachievable for X reasons. Okay, and you put them red, and then the possibles are all in yellow, and then your preferred is in green, and you justify why they're possible and why you've chosen what you've chosen. So that's the options appraisal. What have we got next? Okay. So that's how we've gone through the economic case. Is it value for money? What options have been considered and which option has been chosen and why? The management case I'm going to talk about now is how is it going to be delivered? So again, is that how you're going to do it? Are you going to do it, roll it out? Are you going to pilot it? Are you going to do a big bang rollout on one day? Or how is it going to come about? And then you've got the impact of service delivery, and there's two aspects of that. There's the impact of service delivery overall as a result of your business case going in, or whatever you want to do. For example, you know, if you're doing a one-stop clinic, is that going to free up time in the other clinics? If you've got a new clinic that's a specialist clinic, is that going to free up time in a general clinic? Okay. So that, you know, you have an impact, so you can see more patients, reduce working lists in other ways. So there's the broader impact of what you're trying to do. And then the other bit is impact of service delivery whilst you're doing it. Okay, so what's going to happen while you're rolling this out? How are you going to manage it? So whether it's a new build or whether it's a transfer services, you know, how are you going to make sure there's continuity of your service delivery during this process? So we had, when we relocated our peds cardiac service from our cardiac centre to our children's centre because of the NHS England rules, and we had to do that. But there was a period where, you know, it was all a bit of a mess and being transitioned. So for 48 hours, I think all our emergency peds cardiac stuff was sent to Birmingham Children's. Okay, and similar thing when we had to move our renal transplant service. There was a period of time where I think 24 hours where the kit was in a different place and things hadn't been opened up yet. So another hospital took over our renal transplant service if we needed anything emergency wise. So what's the impact of your service delivery during the implementation? Okay. And then we're going to talk about a little bit about the commercial case. I'm not going to talk about the financial case. Get the financial people involved is very important, is probably what I would say. When you're talking about procurement processes, you've got to think about, and this because we all like buying new things, the whole life cost. Okay, so and it's something that not everybody gets. The procurement teams gets it, but be wary, because what happens is, so think about how long the lifespan of a bit of kit is. So there's no point signing a contract for 10 years if you want, the lifespan of the kit is only 5 years, and there's going to be developments with that time. Okay, and the whole life cost is what's the upfront cost and what's the ongoing consumable cost. So and depending on how much you're going to use it will determine whether it's one is better than the other. Okay, so an example, we use disposable fiber optic scopes to intubate or do bronchoscopies or whatever it is, looking down into people's lungs essentially. Okay, now you have the disposable fiber optic scope and you have the screens. Okay. So then one company might go, actually, we'll give you your screens for free, but each disposable fiber optic scope costs £300. Another company goes, well, and from a kind of quality point of view, there's no difference between them in terms of the quality or the functionality. They meet the criteria. Okay, but the other company goes, the screens cost £100 each, but the disposable things only cost £150 each. Now, depending on how many times you're going to use them, will determine which one's going to be more beneficial over the length of the contract. Okay, if you're going to use them for everything, and you can use them, thousands a year, then paying a bit extra, paying the upfront cost for the screens and having the lower consumable cost is beneficial. If there are only backups and you're going to use maybe once or twice every year, then actually it might work out cheaper for you to get the screens for free. So it depends on how much you're going to use it as to which is going to be the most cheapest way. Okay. Personnel requirements, you just got to work out that when you're calculating things like when you're trying to factor in costs for business cases, you've got to think about anybody that's not a clinician, a medic, is on a 37.5-hour working week. So if you want an extra nurse for a ward, you might need, 3+ working time equivalents to cover an extra nurse 24/7. If you want a clinic to run 52 weeks of the year and it's run by consultant, then consultant contracts and when you're trying to predict these things are based on a 42-week year because of annual leave and everything else. So you need slightly more than one consultant's worth to run a clinic every week of the year. Now, a lot of clinics, if the consultant's not available, they'll cancel the clinic. Because they've been your income is based on a 42-week delivery. Okay, so it depends on how much your delivery is, but just remember that 42 weeks is the kind of the number that people use for the consultant kind of delivery. And 37.5 hours is for the agenda for change contracts. And then you've got contract issues. So, if I wanted a new bit of kit, then, but the trust already has an ongoing contract with a certain company, then I may not be able to get it depending on the terms of the contract. If it's something they already provide, but I want the better version, then I might not be able to do it. I might have to wait till that contract's finished, and then when we're looking to procure the new stuff, the new contract, make sure that my requirements are taken into account. Other issues can be conflicts. So if you buy a bit of equipment that comes with a particular type of computer, and your trust uses a different computer, so we had a kit that came with it had a built-in, I think it was a Dell computer, for example, and we have a managed contract with HP. It meant there was probably 2 months where we couldn't use it because they didn't have the right drivers, and all that kind of stuff had to be sourced, and it was all quite complicated, but from an IT point of view. But there was issues with compatibility. So just make sure you factor those things in when you're looking at your business cases and choosing what you're going to go for. What I would say when you're trying to do your business cases is people don't like change, and if you're having people that are going to be affected by whatever your business case is, get them involved, and look at what their concerns are, and try and incorporate their suggestions, get their support. Okay, because if you make people part of the process, they're less likely to be barriers, and so getting them on board is really important in trying to drive forward your business case. And even if your business case is successful, the implementation may be delayed or may not be as good as you hoped, and the outcomes may not be as good as you wanted if you don't incorporate them, because then they won't help you. And then other things are things like when I said understand the process, look at the appropriate sources of funding. We've had money from the Digital Transformation Fund, which is run by NHS England, and so we got money for our e-consent program and our electronic pre-op assessment program based from digital transformation funds from NHS England. We had a negative education report from our trainees about facilities and various other things, and we used that to build a hub, a kind of an education hub within the anaesthetic department. Create an anaesthetic department first, then build a hub within it. But that most of the money from that came from the education budget because it was to do with training. And we wouldn't have got it if we had to go through the normal capital funding route. So again, look at the different sources of funding depending on what you're trying to achieve, and then look at system funding, which is based from ICBs, which is currently separate from specialised funding. So NHS England might be able to fund you if you are primarily doing with specialist stuff that's commissioned by them, whereas system funding is for the more generic stuff. There are often pots of money towards the end of the year, so kind of February time, particularly capital funding. There's often underspends in different pots, and money is allocated into different groups, and you have to spend it in a certain particular way. So again, towards the end of the year before, we had an environmental, the ICB. So our system had a pot of environmental funding, which I again used to get more pumps for Tiva. And this year, what did we get this year? Did we get anything this year? We got some furniture for our hub this year from some capital funding. If you want to try and do big projects, it's a new services that require ongoing funds, getting it to start in April, the financial year, and building that into the funding is quite useful. So just timing is quite important. And if you've got a small business case that fits in with a larger business case, then you can often, particularly the capital ones, you can often put them in with them, and they tend to be successful. My name's quite long, so the easiest way of getting in contact with me is ak@clinical.finance. So any questions? I've got 10 minutes. Well, I haven't got 10 minutes. There's 10 minutes allocated. I'm happy to stay for as long as needed. For any questions on anything from today. So in terms of how long it takes, it depends on how many hoops you've got to go through, essentially, and that's dependent on the value. So small value business cases can be approved by your department. Higher value might need to go to your trust board, and the really big ones need to go to either the ICB or NHS England. So it really does depend, and they have meetings, set meetings across the year. So I've been asked to, there's often deadlines for putting through a business case X number of times, and the number of times I get asked to look at a business case and look at it a week. Well, I've had to do it on the deadline day before and revamp a whole business case on deadline day because the meeting was the next day. So yeah, they have most areas have meetings at regular intervals across the year. You'll also find that at different times, different barriers get put in. So at the moment, our trust are under the cosh financially, so they've got a recruitment panel. So even if you've got a business case approved to recruit, we have to re-justify it now, and whether we need it this year because we are under a lot of financial pressures at the moment. So there is no good answer, easy answer for that. So there is a committee that judges the business cases. There's often, and again, it kind of depends on, again, the cost of the business case. If it's a business case that requires wholesale major changes that's like millions of pounds, then it'll need to go to NHS England to get approval. So you need to go through various barriers to get through that. If it's a small business case, it can be directorate specific, but most of them go to a specific panel within. If it's just general trust fund, then it has to go to a specific panel, a committee within the organisation, which then approves it, and they'll review. They've got criteria, and they'll review X number of business cases per session, 3 or 4 times a year. Right. Well, I hope you found it useful. I hope you found it vaguely interesting. I know it's not the most interesting of subjects. You should have had the slides already, and some of the slides that have been sent out should have slightly more than what I presented, just to give you some context and some. But I didn't want to put massive screens of writing on here either. You'll get a feedback form so that we can improve, and we have tried to. So I've taken the feedback from last time about sending the slides out early, and you'll get a link to the recording with your feedback form, and trying to make it a bit more interactive. So hopefully this has worked. If the Slido wing works, that's great. If you have any tips, let me know. I'm happy to take anything on board to improve. But I'll hang around if anybody wants to have any questions.
Thank you.
Thank you. If you haven't had the slides, email either. If you're from the Southwest Deanery, email the Deanery. If you're from the One NHS Finance, email one.finance@nhs.net, and they'll make sure that you get the slides. Email them, they'll be able to make sure you get the slides.
Thank you.
Thank you.
Thank you.